Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everyone. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today we're going to discuss one of the more nerve-wracking situations in all of EMS and emergency medicine, and that is the critical bradycardic patient, and specifically how this relates to transcutaneous pacing. Who do we pace? How do we recognize if pacing is working? And what are our fallback options if it doesn't? There are definitely some learning pearls and some learning pitfalls here, and we have a couple special guests to help us talk about some of the most recent evidence regarding transcutaneous pacing in EMS. We have Josh Kimbrell and Judah Kreinbrook, who recently published a paper in Prehospital Emergency Care looking at pacemaker success or transcutaneous pacing success in EMS. But before we get into the paper and get into the discussion, Josh, Judah, will you please take a second, introduce yourself to the listeners? Where are you now? How did this project come about?
Sure. So this is Josh. I'm a paramedic turned medical student. I live in New York City now. I started my EMS career down in New Orleans back in 2016. Worked as an EMT. I got my paramedic. I kind of fell in love with the field and resuscitation broadly. In January 2020, I moved up to New York City. I spent some time working not just in L1, but also in critical care, some pediatric critical care, and ended up stepping into a quality improvement role. I was a quality manager for big EMS service in New York City. And now I've kind of pivoted a little bit. The last couple of years, I've gotten really involved in EMS pre-hospital research. And just this past year, I started as a medical student in the Albert Einstein College of Medicine. I always identify as a paramedic first and a medical student second. We'll see if that changes, but that's kind of where we are now. So excited to be here. I'm a longtime listener to the podcast. You do great work, so thanks for having us.
Yeah, and I'm Judah Kreinbrook. I was a medic for 4 years, EMT for 2, down in Sumter County, Florida, one of the more under-resourced counties in Florida, about right smack dab in the middle if you look at Florida on a map, and really cut my teeth in the semi-rural to rural part of the county, south end. Had a lot of, interesting demographics. We had federal prison right up the road. We had an interstate running through. You were at least an hour away from most centers that had really robust cardiac care, stroke care, trauma care. And so making those decisions early on kind of made me fall in love with where do we take patients? How do we make these decisions pre-hospitally? But eventually, I really loved cardiac physiology. Since moving on to medical school at Duke University, I've really kind of started heading towards the path of becoming a critical care cardiologist who is not only a friend of EMS, but actively involved in pre-hospital research. I'm really interested in out-of-hospital cardiac arrest states and critical cardiac states physiologically. I'm currently in my master's of clinical research at Duke, and my current projects focus primarily on out-of-hospital cardiac arrest with the eventual goal to become a resuscitation scientist.
Excellent. Well, thank you both for joining us. Appreciate the kind words about the podcast. Thanks for listening. So, Josh, I know I've heard you tell this story before. I want you to tell it to the listeners because there's some points here that I really love. Tell the listeners how this project came about, because I think when we hear research scientists and the ESO database and we start to get into stats, I believe the paramedics and even medical directors out there in the world sort of can gloss over, and it's not really their day to day, and it doesn't really apply, I think, is the way that a lot of us can feel about research as a whole. But the genesis of this project to me is one of the more interesting points.
Yeah, thanks for bringing that up. So I guess as a starting point, I had no research training whatsoever. I was a paramedic. I worked in quality improvement. My job was to ensure that we gave the highest quality care all the time. And so we do about 60, 70,000 EMS calls a year. And one of my passion projects was cardiac arrest. And one of my passion projects was kind of emergency cardiology broadly and improving our care. So back several years beforehand, I had read some of the blogs from some of the listeners may know Tom Bouthillet, who is a paramedic, quality improvement leader, kind of transcutaneous pacing master, you might say. And he did quite a few blogs on false electrical capture. So the long story short of false electrical capture is when you put on those pacer pads and you fire it up and your patient's getting that transcutaneous pacing procedure, you end up having this artifact on the monitor that is really confusing. He calls it a phantom complex. Basically, there's this big arcing wave that's huge on your defibrillator, and so you're sitting there looking at your life pack or your Zoll, and this phantom complex actually obscures the QRS, and so you think you have capture when you really don't. And so this is something that I read about a while ago. It had been talked about on Twitter and kind of among my paramedic friends. But when I actually brought it up to our medical director in New York City, I said, "Hey, I found these false electrical capture cases." They said, "What is that? What are you talking about?" And so I did a little PubMed search, and I searched false electrical capture transcutaneous pacing because I was going to send some articles. I found that there was actually nothing. This had only been talked about by really smart people in the paramedic world, but it hadn't actually been published in peer-reviewed literature. And so I actually sent off, an email or a Twitter DM. I can't remember what it was, but I reached out to Tom Bouthillet and I said, "Hey, we have quite a few false electrical capture cases in our kind of patient database here. We have that we use for quality improvement, and I saw there's really no research on this, and I want people to talk about this. I want people to know that this is a problem." And he said, "You're absolutely right. Let's get started." And from there, I reached out to a friend, Judah, as you met before, is another paramedic that is now a medical student. And we said, we want to publish this in the literature and get this out there, mainly because I want other systems to know that this is a problem and know how to fix it. So that's kind of the genesis of this study.
So to distill that for the listeners, almost all of our EMS services out there have quality departments and a quality lead like Josh was. And we're looking at these calls. We're looking at Zoll LifePak data. We're looking at timestamps and vital signs day in and day out, treatment protocols, transcutaneous pacing, and all the others that involve critical EMS care. And those quality concerns led to a question, which led to a lit search, which led to the idea that there's nothing out there about this. You reached out to a thought leader and really in a paramedic EMS EKG guru, cold call, I would assume, probably, or a pretty cold call. You got some expertise and you turned it into a peer-reviewed article, which others can cite, can teach from, can look at the pictures and the PDFs that are in there and learn. And to me, that is the way that EMS research should work, or at least that should be a large component of it. Our own cases and our own questions are driving the research topics that we decide to pick. So that gives me enthusiasm for what we do at MCHD. A lot of similar progression in some of our projects. So I really think that's applicable to everyone out there that's listening, because that quality person exists in your EMS service, and that's the kind of thing that we should be doing and should strive for. So kudos. Let's talk a little bit about the manuscript. I don't want to go into a full-bore journal club discussion, but I do think there were some real massive take-home points when I read through this. I'll let you guys share this. Take me through some of the big key points that you found, what you would want to give in your elevator speech. If someone asks you about this paper and they want to know, hey, what did you learn? What were the main points? Hit some of those for me.
Yeah, so I'll start and I'll let Judah kind of fill in where I'll leave some gaps. So essentially, we looked at 23 different patients over 2 years that are kind of multi-division EMS agency in New York, and we found that only 4 of those 23 patients had true electrical capture on review, right? And so this process of trying to interpret while you're on the scene, you have this critically unstable bradycardic patient. You're managing 100 things at once. You're probably trying to get your epinephrine infusion ready. You might be intubating this patient. You're working on access, and your partner's trying to put the pacer pads on, and it's a difficult situation. So I think through the whole thing, we weren't critical of the paramedics there. We were just trying to provide an objective kind of review of what happened. And what we ended up finding is that, and obviously we couldn't necessarily look at who had mechanical capture, right? We're not able to kind of look at that heart, have an ultrasound. We didn't have any ultrasounds in our service. We have no real idea whether the heart was beating. But what we do know is that those, 19 of those 23 patients with false electrical capture, they had ECG waveforms that were not consistent with an actual QRS. And what we found was for those patients that did have the true electrical capture sustained throughout the call, they had an increase in blood pressure, much higher increase in blood pressure. I think a delta of 40. So the blood pressure after administration was 40 points higher for those that had it, and it was no difference for those without. And what I thought was probably my most concerning point was every single patient in this cohort, the paramedics described mechanical capture. And this is something that I think is, to me, is our biggest take home point is we know in cardiac arrest care that pulse checks aren't super reliable for identifying pulses. But when you add in the complication of, when you have that pacer on, and especially in the AL position, you're actually having a lot of muscle twitching and movement, right? So trying to feel, especially for people trying to feel a carotid pulse, or even if you're feeling a femoral, or maybe trying to feel a radial, sometimes that muscular movement can be difficult to discern from a pulse. And so I think we had that really false reassurance there. And I think another point that we noticed is a lot of these patients were post-arrest, and of our 11 post-arrest transcutaneous pacing patients, none of them had electrical capture, which could be from a variety of reasons. But I really worry about those patients because not only are we not giving a good intervention, but we might be missing an underlying rhythm. For example, if you have pacer pads on and all you're seeing on the monitor is this wide artifact, and you think it's a QRS complex, you think it's electrical capture, but it's really asystole, then you're not going to recognize it, and we're not going to be doing CPR. So really, really scary, the kind of implications that has.
Yeah, I think Josh pretty much summed up the main take home points. I want to, provide a little bit of a broader look at how this project developed from the quality standpoint, and emphasize why that's important, because this doesn't just extend to quality managers. This extends to paramedics in the field. There have been paramedics for years that have followed Tom Bouthillet's blog, talked to him about this false electrical capture. And the question becomes, our findings really call into question the ability of a paramedic to assess mechanical capture. And I think that when scientific literature calls into question clinical practice, there's this tendency for any clinician, be it paramedic, nurse, physician, PT, OT, like whoever in the medical space, we don't like to be told that we're doing something that may not be helping our patients, because we all want to help the patient at the end of the day. And it's important that, even though the caveat is we didn't go setting out to find something that shows that, paramedics widely thought that they had mechanical capture in this case, and it turns out that electrical capture wasn't really present in 19 out of the 23. But this should humble all of us that we as human beings, we can't always assess what is going on with our patients, because we have limitations. And like Josh said, we didn't have ultrasound in this study. Ultrasound really hasn't been ubiquitous. Other than the, mechanical capture findings and, these findings in post cardiac arrest, I think there were some interesting points that came out of it. And we can talk about this more in the Pearl section, but we had a case where pulse oximetry pleth waveform was perfectly synchronized with true electrical capture, showing promise for that method maybe to assess if true capture exists. And I know one of the kind of the discussion points here is, what findings most surprised us. I think personally, it was surprising to me that there wasn't a single case of false electrical capture where a paramedic recognized it and turned the device off. I think that this fits with Tom Bouthillet's teaching for the last, nearly decade, where this echo distortion, these phantom complexes that we see, they really do mimic a QRS. And so again, it goes back to, I think that this data should humble us with, just this procedure in general. And, later on in the podcast, we can talk about maybe some other papers that have come out and what they're starting to show, because there is some emerging evidence here as well. That's just kind of what I wanted to add.
Let me chime in. There's some really excellent points in there worth reiterating for the listeners. First off, for the listeners out there that have not read this paper, we will link it in the show notes. There were 23 patients that were paced that were believed by the paramedics to have mechanical capture, and only 4 of those, upon review, were suspected or believed to have actual mechanical capture. So that's a staggering number. I would have thought that the discrepancy there would have been large. I wouldn't have predicted it would be that large. Both hit on the point that we've dealt with in an entirely different world, a different patient population, but is really the same issue, and that is the difficulty that we have. And I say we because we've got paramedics on the podcast, we've got an emergency physician, we've got med students, nurses, ICU physicians, anesthesiologists in the literature for decades showing that we all are very terrible with accuracy of a manual pulse check. And then to Josh's point, we throw on 120 milliamps, and why would we suspect that we would be any more accurate in that situation? I can't imagine that we're going to be anything but significantly less accurate as compared to a cardiac arrest situation where much of that data stems from. So we have used ultrasound here at MCHD to try to do a better job of pulse checks in our cardiac arrest situations. This is, talking about where we may go in the future here, preview of coming attractions, to Judah's point, confirming mechanical capture and true perfusion with this. Ultrasound seems to be an obvious answer, but then it has to be ubiquitous enough to use. And then we had a case at MCHD talking about quality driving our education. The case that drove me into this paper and into this literature a little bit more, because I was not in a different boat than your New York City medical director, Josh. This is not something that I've looked at closely or any way, shape, or form an expert in, but we had a cardiac arrest case where we missed asystole because the patient had their implanted pacemaker active. And so it led to other questions, but anytime that you have spikes on the monitor, whether it's your transcutaneous pacer spikes, which are going to be huge and very disruptive, or even an implanted pacemaker or AICD pacemaker in a patient who's in arrest, those distracting electrical complexes make assessment of asystole much more difficult. So if we're doing something that doesn't help and we're missing asystole and we need to be doing compressions and cardiac arrest management, to Judah's point, that's a huge miss. So let's talk about these pitfalls that you saw when reviewing these charts and pair that with, okay, we saw these pitfalls, we've gathered this data, we published this paper. How do we take that to the next step? How would you redesign a protocol? How would you consider education going forward? And you can be as narrow, as broad as you would like, but each of you take pieces of that and talk about what we do with this. So now we've got this cool paper and we've got this cool data. What's next?
Yeah. I think one thing I would lightly correct you on here, and it's great that this actually came up, because it's something that we kept making this same kind of error when talking about it. Is you said that none of these patients had mechanical capture, and we kind of thought, like, how do we justify without having ultrasound or an arterial line that none of the patients with false electrical capture really had no mechanical capture? And it really is this logical relation. If you don't have electrical capture, you most certainly don't have mechanical capture. And we've been taught historically that both electrical and mechanical are different, and that comes from the wider cardiology literature. But if you actually look back at the historical trials of transcutaneous pacing, they were originally on devices that didn't actually have EKG capability. And so they started off at the maximum current of the device in an anterior posterior position of the pads, and they just rolled with it. They saw that it wasn't working in Brady asystolic cardiac arrest. That's actually where TCP devices were first pioneered, but they saw that it was working on the subgroup with symptomatic or unstable bradycardia. And so I think that one of the big takeaways here is that, like you said, mechanical capture determination is difficult. And why we were so confident in our results was because, blinded to everybody, we saw an increase in blood pressure in the patients who had true electrical capture, supporting the idea that likely they had mechanical capture. But even that, we don't know. As far as how to design a protocol and some pitfalls that we saw, there really are three categories of false electrical capture. There are cases that we saw where, when the pacer is turned on, there's that echo distortion or phantom complex. It's wide and swooping. It looks like a QRS, but it doesn't have a very clear, tall, broad T wave. And that comes from the pacer, and it actually increases in size as you turn the current up. We saw that another subset of false capture were dissociation. There, you saw that there were pacing complexes intersposed with native QRS complexes from the underlying rhythm that began prior to the pacer. And then finally, you see these cases that are a little bit of both. It's kind of a phantom complex or echo distortion with this interpose. If you're using a life pack monitor, the great part is that it will actually pick up those native beats. And so that second and the third, you really should be seeing those triangles over top those native beats. If you see that, there is almost no chance that you have mechanical capture, or I'm sorry, electric. You can even see I do it all the time. There's no chance that you have electrical capture, and definitely no chance that you have mechanical capture in that case. I think that there is some recent literature to suggest that the anterior posterior position, you're more likely to get capture at a lower electricity. I think that this historical deep dive that Josh and I did, and we actually published an editorial in Pacing and Clinical Electrophysiology, reviewing these historical trials, they all started in AP position. It was mandatory. Why are we starting in AL? I think the reason is because most of the time we're using this therapy, it's in the post-Ross setting. Our patients are breathing down, and we're seeing that most providers are in AL position, right? So it's a matter of convenience. But really, how long does it take to get yourself set up for success, getting to that anterior posterior position, right? Another key thing we saw in these 4 cases that had true electrical capture, and I think that is the hint towards designing protocols. I think we saw that there's a clear transition from this phantom arcing complex where you're starting at whatever current setting you start at low and you're going up, and you will see a transition with that echo distortion phantom complex to a fairly clear, I'd like to call a J point and a tall broad T wave, right? It loses this kind of swooping nature, and we'll have attached pictures to in the show notes, because I recognize that again, this is difficult. I think that these proxies that we use, blood pressure, SpO2 plath, end tidal, all of those are proxies. They're imperfect tools for imperfect medicine. The true gold standard of whether you have mechanical capture, and Dr. Patrick, you can say this from your emergency medicine practice. If you guys are floating a transvenous pacemaker, you're looking at the heart with ultrasound to see if you have mechanical capture. That every time that pacer beats, every time it delivers a current, you're really getting a squeeze. I think that's the gold standard, and everything else, you should be really skeptical if you have true electrical capture unless you've clearly seen that transition from this phantom complex, a dissolution of, resolving complete deletion of the native rhythm. On LifePak, you should have no triangles still left. And then you see that transition to the tall, broad T wave. I don't think that anybody should feel bad about not knowing this. This is not how we were trained in ACLS. It always looks like a beautiful paced rhythm. There's no real phantom complex, but it's kind of what I have to add on my thoughts as to redesigning systems of care towards getting capture in most cases.
I really think that ultrasound will become the it'll become the gold standard confirmation for transcutaneous pacing, the same way that waveform capnography has become the gold standard and really standard of care to confirm advanced airway placement. But a lot of EMS systems out there aren't necessarily rolling around in lots of money, right? I know that in our EMS system where we did this study, we serve a predominantly impoverished immigrant community in South Queens, right? We're not making lots of money. I don't think we're going to have ultrasound anytime soon, right? And so while I think that's probably the ideal, realistically, paramedics are going to have their pacer pads, they're going to have some medications, they're going to have their physical assessment skills, and they're going to have to make do with that and do whatever the best they can for the patients. And so I think if like kind of targeting the individual first, those paramedics, the first thing I would say is, and Judah hit on this a little bit, like be skeptical, be very skeptical that you have capture, right? I think we get in this false reassurance when we're taught in ACLS or in paramedic school or wherever we are, we're kind of taught that you raise the pacer up to a current of like 70 milliamps, and all of a sudden you get this beautiful rhythm on the monitor and you're all done. And our median false capture current was like 70 milliamps or 75 milliamps, which I'm convinced is because that's what we were taught. We were just taught that we would raise up that dial and it would get there, we would set it, and we forget it. And I think instead to think, look, you should be skeptical you have true capture at any current, but you should be really skeptical under 100 milliamps. And I say that with a low level of confidence, right? We don't actually know exactly the right current, but I think it's very unlikely you have it under 100 milliamps, and you should be really skeptical. I think you should be using all of the tools at your disposal. When you're feeling for a pulse, you should be feeling a femoral pulse, right? We should be, if you have that ultrasound, use it. If you have pulse oximetry, you need to look and see if that pluck wave matches up with each pacer spike, right? What we end up having is we have pluck waves and we have pulse palpation, but if you have an underlying rhythm at a rate of 40 and your pacer at a rate of 80, for example, you're actually going to feel a pulse. You're just going to feel it half as often. And so it's already difficult, but it's compounded by all of these things. So I think being really skeptical is one point. I think second, know your monitor, right? If you have a LifePak 15, you should know that the default method, unless your manager or operations person changed it, is demand pacing, right? So it's only going to give a pacer fire if the underlying rhythm is below the rate that the pacer is set at. So if you put it on me right now, my heart rate's probably in the 80s right now, maybe in the 90s. Maybe I'm really excited talking about this. And you put those pacer pads on me, you'll actually find that if you set it to a rate of 70, that it's not going to give me any pacer fires at all. But you need to know that about your monitor. Additionally, the LifePak will actually have a little triangle. Judah was talking about this earlier. A triangle, kind of like you have with synchronized cardioversion over each QRS complex. And that's your signal that it's not actually coming from the pacer. It's coming from that underlying beat. And so if we end up in a situation where we're transcutaneous pacing, which already doesn't happen a lot, even if you're in a high volume system, we're doing pretty limited amounts of transcutaneous pacing per person. And so, approaching that with a lot of humility and saying, you know what, I'm going to really research. Okay, I have a Zoll device. Does your Zoll, because you can change this, does your Zoll obscure the pacer spikes? Some of them will hide them on the ECG strip. Some of them won't. Knowing that stuff in your individual system requires subject matter expertise. I think like more broadly at the like kind of paramedic system level, at the protocol level, at the manager level, as you're designing protocols, I think it's really important, number one, and this is not limited to transcutaneous pacing, it's everything, but people making those protocol decisions should not just be the medical director that spends 90% of his or her time in the ED. It shouldn't just be the division chief that hasn't seen the inside of an ambulance in 10 years. You need to get the frontline paramedic and EMT staff into those offices and make those protocols together. Because you may think it's really simple, but you actually didn't know that XYZ reason that this strategy won't work. And so I think bringing in those frontline clinicians is really important. I think secondly, mandating the use of capnography, pulse oximetry, and distal pulse palpation is a good step in your protocol. One thing I was really excited about, somebody sent me a protocol from Mayo Clinic Ambulance Service in Minnesota. They have some of actually our pictures from our case study or our study that we're talking about today, with true electrical capture and false electrical capture to really show that. I love that. Use pictures, show exactly what it's like, because this is really hard. We know that this is really difficult, and it's not the paramedics' fault. They're doing 10,000 things at once, and this is really difficult to do. And I guess just the final point is, really taking a methodical approach to this, right? Every patient should get a slow increase of that current until you see a change in morphology. And you should be really suspicious of anybody getting captured, but especially if it's under 100 milliamps. And then you should confirm it with all of your techniques available. If you have POCUS, you should use it. If you don't, you should be using capnography. You should be using pulse oximetry. You should be taking frequent blood pressures, and you should be really, really skeptical. And that can help improve your care for these patients.
Yeah. Love it. Love all of those points, guys. I'm going to do my best here to summarize for some take-home points and let you guys have one last sentence or two. First of all, we've got to pick the right patients. Judah alluded to this. My belief is that post-ROSC patients will very rarely be patients that we need to pace. Those patients are so heterogeneous and so sick that transcutaneous pacing really isn't a good answer for those patients almost all the time. If we're bradycardic from an overdose or from hyperkalemia, from sepsis, from a PE, from some other systemic illness, transcutaneous pacing is not going to work. The right patients for TCP, both in the emergency department and the field, are those primary electrical patients, the third-degree blocks, the sick sinus syndrome. Those are the ones where we can make a difference. We're not going to transcutaneously pace successfully a patient with a 100% LAD lesion or potassium of 8, and so we shouldn't try. All of these proxies and these proxy pieces that Judah and Josh talked about are vital for helping to give us more information. If our blood pressure jumps up 30 points, more likely to have true mechanical capture. If our end tidal jumps up and our perfusion improves, we're more likely to have true mechanical capture. If we see a pleth waveform that matches our pacer rate, we're more likely to have mechanical capture. None of these things are foolproof, but if we have a pleth waveform of 40, a blood pressure that doesn't change, an end tidal that doesn't change, that mechanical pulse that you're feeling is much more likely to be false. And so use those rule out pieces to help us, guide our care. And if we don't have electrical capture on our 12 lead, then it's highly unlikely that we're feeling a pulse. And so looking for that T wave in there, that depolarization is important. That gets a little more technical, a little more difficult, but learning from these pictures and thinking about this is just going to make us better in the future. And then the end answer, when money is no issue and technology becomes more affordable, we'll be putting that ultrasound on the heart and looking for squeeze. So anything I said there, guys, that you'd like to correct or sand over, please go ahead. Otherwise, thanks for joining us today. Excellent discussion. We've got lots of learning and revamping and education going based on this entire discussion at MCHD. So you can throw MCHD in the mix with Mayo. I like to be in that conversation. We're adding a lot of these same pictures and these same educational points this year as well.
That's great to hear. I think something I'd like to sand over a little bit there is I don't know if we know that, the hyperkalemic patient, the septic patient and whatnot, I don't know if we know for sure that transcutaneous pacing may not have some role. I think for now, it's probably best to focus on your other interventions. And most of the time that you're going to transcutaneous pacing in those people, because they're probably going to be in sinus bradycardia, you've already tried out, all your other interventions. And I, totally agree with that. I think that just underscores how much of a scientific frontier this is, and we look forward to providing more evidence for the listeners. We currently have a multi-center retrospective study in progress and hope to have those results out by the end of the year if possible, to really help generate the evidence that is going to hopefully guide practice going forward. Transcutaneous pacing has never proven itself superior to vasopressors and other medications in trials. There was one feasibility trial back in 2010, but we don't know what the capture rates were in those trials. So this is really an open area for investigation. And this, this podcast is focused on what can you do right now on the basis of this small study on the front lines, but be skeptical, be curious, and be humble, because there's a lot we don't know here.
Yeah, and I'll add just a little bit. I think we talked about it a little bit, but I really want to stress that anterior posterior pad placement is probably a key to better electrical capture rates. We do have some actually high quality evidence from that. The only other thing that I would mention is to any of the paramedics listening that are interested in advancing research on their own end, we need more paramedics doing this work. We need more people out in the field using their lived experience as paramedics to improve the quality of pre-hospital research. This transcutaneous spacing is wide open, and so are so many things in pre-hospital care, and it's exciting to see where we are and where we'll go. So
I got to tag on pharmacology first. That has definitely been our teaching at MCHD, breaking a little bit of paramedic teaching, I believe. There's a little discrepancy there as I've gone through this. Push dose, epi drip, atropine, transcutaneous pacing as really the fourth option there. And to Josh's point, we should already be in an AP pad position anyways. If you're following Dose VF or Dr. Chesky's from up in Canada, we're already AP pad folks for all of our arrest situations at MCHD. So why not just make everything AP to start, and then you don't have to really think about that piece, and you're going to be in a better position. So if you're not doing that, I would urge you to move that direction. And in the septic hyperkalemic patients, we surely should be, for those septic folks, with vasopressor, push dose, vasopressor drip, plus or minus atropine. If we suspect hyperkalemia for the MCHD listeners, we're thinking about calcium, albuterol, and bicarb for those folks. So hopefully we can carve those out. And whether or not TCP has a role in those patients, to Judah's point, who knows? But we surely think it should be further down the list of options. And
absolutely,
from our evidence, they don't tend to do well, but we never say never for sure. And if that's an option that you feel like you need to utilize through your protocols at your service or in ours at MCHD, that's going to be a clinical decision in those individual cases. So thank you both for joining me today. Really, really appreciate the discussion. I could go for another couple hours because there's so many excellent points in there, and maybe we'll have to just split it up and pick some of those pieces and have round two here, because I've really enjoyed it. As always, if you have questions, comments, email us, podcast@mchd-tx.org. Subscribe, whether you're listening on your favorite podcast source or you're watching on YouTube. Hit subscribe, hit like, send us feedback. We always appreciate it. We'll be back with another episode again soon. Thank you all for joining.
This podcast was brought to you by the Montgomery County Hospital District, Texas. Production and editing by Andrew Adams. Questions or comments, which are always welcome, can be sent to podcast@mchd-tx.org. Make sure to subscribe above to keep updated to all our future casts. Music, copyright, Kevin MacLeod, Incompetech.com, licensed under Creative Commons by Attribution 3.0.